Thank you, sir, and good afternoon, everyone. I think it's a post-lunch session. You'll be dozing now, but I try myself like to be loud so that you'll not sleep. And sorry for not joining you like live session. I'm able to deliver my talk virtually due to unforeseen reasons. So today, my topic of discussion is selection of treatment for RCC in adjuvant as well as first-line treatment metastatic setting. So adjuvant treatment, which is most talked about right from my student days. So what are the current treatment options for the adjuvant setting? So stage 2, stage 3, we like scale down to these stages to provide the adjuvant options. Let us go to the discussion of the TKS, oral as well as immunotherapy. So first the TKI, all of us, many of us used to use sunitinib as an adjuvant therapy when the DFS outcomes were there. As the time passes, there is no overall survival difference by adding sunitinib in adjuvant setting. So it remained to be a category 2 indication now, and none of us are using unless the patient is unaffordable for immunotherapy in a very high risk like M1 disease. So Assure trial, Extract trial, there is some difference in the inclusion criteria, the kind of stage they included. Extract is having a significant, very high risk disease. So by adding sunitinib, there is some difference in the DFS which is meaningful, but OS down the line has like clubbed each other. And pazopanib, again, there is no benefit is there. And next oral option post TK, like other than TK, what other oral option we have is everolimus. Everolimus Everestil also has like been tried in the very high risk as well as intermediate to high risk disease. The Terenci QD per day, like 54 weeks were used for high risk, very high risk and intermediate high risk. And again, there is some difference in the PFS is there, which is not so meaningful, which is not statistically significant, and OS is said to be updated. So very high risk, there is some benefit is there, but again, p-value is not so significant, so it is not enabled into practice. But definitely, sunitinib, many of us tried, still trying because it is still a category 2 indication in the NCCN. So coming to the blockbuster molecule, like out of all the immunotherapies tried, be it atezolizumab, nivolumab, pembrolizumab stood test of time. That's a keynote 564 trial, 30 months follow-up is there. That's adjuvant pembro versus placebo for clear cell RCC. It included not only just high risk, it included the M1 disease, like which is a metastatic disease which got resected, or oligometastatic disease which got resected. And so this group got included in this one. Pembrolizumab 1 year versus placebo got tried. So there are three categories totally: intermediate risk to high risk, M1 with no evidence of disease. So here the DFS is significantly different at 24 months, 78.3% versus 67.3. The hazard ratio is 0.63. And all risk categories got a significant benefit by adding pembrolizumab for 1 year. And if you see here, the high risk and M1 disease, the curves are so stark. Still, the DFS is not reached. So M1 disease, like if ever any of us use the TK, like most of us have seen within 2 years, definitely the relapse risk is very high. But pembrolizumab, by addition of pembrolizumab, we see at 24 months, it is 78.4% people still like remain disease free, which is really significant. I really consider this option both M1 as well as high risk strongly. So the sarcomatoid status, which is again very poor prognostic factor, both irrespective of the sarcomatoid component, there is a good benefit is there. So usually sarcomatoid is a very aggressive variant. If you see here, there is a good benefit by adding pembrolizumab 1 year. So OS still like it hasn't reached, comparison cannot be the criteria of significance in this analysis. Maybe after 200 events, if it got conducted, we can comment on this. OS, again, there is no difference at this point of time, but still the events haven't been recruited or recurred to comment on this status. So overall, the conclusion is out of all the immunotherapy as well as TKs are like oral drugs tried currently, only the pembrolizumab has proven the benefit. It's to test of time. There is significant DFS benefit is there. It met the primary endpoint criteria. OS had to comment upon because the events are not occurred. So we still have to wait for the data of the OS now. What is the future directions and unanswered questions? Duration needed for the adjuvant therapy for resected or radiated oligometastatic disease is still unknown. Is 1 year enough or it's too much? The intensity of adjuvant treatment for resected or radiated oligometastatic disease. risks of toxicity, and overtreating or undertreating patients. So these answers are yet to be answered in these questions are yet to be answered in the adjuvant setting. What is the first line treatment in the adjuvant RCC? So it's always like we have to risk stratify the patient based on the performance status, time from initial diagnosis to the treatment, hemoglobin, calcium levels, the other inflammatory markers like neutrophil count, platelet count. Depending upon the number of criteria for positivity, favorable, intermediate, poor risk category will be there. So depending on that, the outcome is like totally different. We all we all agree that favorable risk we can offer TK, IO plus TK. Intermittent poor risk like IO combination, IO VEGF combination, VEGF TK if the patient is not affordable can be offered in the first line. So how we choose it? Why favorable risk like we have to choose this? Why not that? Why intermittent poor risk we can in which patients we can choose this combination? We will discuss thoroughly. I just like kept the slides on the background, like, but I do discuss other points clinically, how we choose the TK or any other treatment option in the different risk category groups. So the briefly, the Carmina update, like, which got presented in 2019 in a patient who are having a metastatic disease, there is no benefit of like doing the surgery. We can just give the TK was the discussion then, but some patients still we can consider nephrectomy. It makes sense, which is the patients who are having a minimal extrarenal disease or oligometastatic disease, like whoever are there. So those kind of patients we can consider nephrectomy, or who are having the bleeding or significant hematuria, we can consider nephrectomy. But with the era of the immunotherapy plus TK combination, this question still like remain doubt to me. So it has to be answered in future with other trials. But Carmina with TK, there is no difference whether do surgery in a patient who are having a significant burden of disease. So currently favorable group, you can offer TK plus immunotherapy or TK. Poor intermediate, like again IO plus IO plus TK we can use. And TK always remains option because 80% population like doesn't, they cannot afford for the immunotherapy or like slightly pricey TKs like cabozantinib or axantinib. The first one, which is the first trial, like which is very important to discuss, is the IO plus IO combination. That's a checkmate 214 trial. So why this is so important? Because when this trial has happened, the significant number of CRs like was a debate then. So number of CRs are very high in the checkmate 214 trial, the IO combination. So let us discuss this one. If you see the OS again. In the intermediate to poor risk, there is a significant difference in the OS is noted, and again when it comes to favorable risk, there is not much difference is there. But as the time passes, if you see, as the time passes in the favorable patients also, there is a good benefit is there. As the time passes, there is a benefit of OS also there. Long-term survival is improved with the IO plus IO combination. Initially, it was detrimental, it was discussed as detrimental using IO combination, but as the time passes, if you see the curves are like different, they separated. The patient, whoever responded, they remained responded to the IO in the favorable risk also. That was the debate now. Even the favorable risk, it's not a wrong idea to offer IO plus IO because there is a significant number of CRs are there in all the groups, especially in the favorable groups. So it's it's not a wrong idea to give the IO combination favorable group also. The CRs, the oral response rates are decent enough. The duration of response is not yet reached in the intermediate poor risk now. So it's a decent option to consider IO in the favorable risk also. Irrespective of the risk category, we can offer this one. And next is the keynote 426, the first line pembro plus axantinib versus sunitinib in advanced or metastatic RCC. We see all trials like the IO plus TK, IO, they compared with the sunitinib now. It's not with the same TK, they compared it with the sunitinib, it was discussed, which was a standard therapy then. If you see here again, the all risk group, there is a good benefit is there by VEGF inhibitor plus pembro combination versus sunitinib. And here, if you see, there is intermediate poor risk and favorable risk. Again, there is a tail ring, like at the end of the tail, there is a tail of the curve got separated. There is a good benefit of like giving immunotherapy plus TK combination. It's a good option to offer for favorable risk also. Irrespective of this, we can offer TK plus IO combination. And again, 9-year trial, nivolumab plus cabozantinib. Again, this is also very promising one. As the time passes, like the poor risk category, there is significant benefit is there. All risk category also there is a good benefit is there. If you see here the median OS in the poor risk, the significant stark benefit is there. Again, if you see there is as the time passes, there is a good benefit with the IO plus TK combination. This is a favorable risk. And next is a clear one. Most of us are fan of this combination. It's a pembro plus lenvatinib combination. If you see the all risk group, again, there is a lenvo plus pembrolizumab combination has scored really well in this. And all the risk categories, like though favorable, there is slight erring towards that. But as the time passes, again, the IO plus TK combination stood out starkly. So again, as the long-term follow-up happens, always IO is a preferable option in the favorable risk also. So the different risk categories, if you see, intermediate and poor risk. But what was the discussion among the peers was the quality of life, bone metastasis. Now, just I discussed in the, regarding the few trials of IO plus TK combination. But what was the discussion regarding which group of patients should be offered certain combination was the discussion. So when they did the quality of life analysis, checkmate 9-year, that's a nivo plus cabozantinib combination. There is a good quality of life got maintained compared to the lenvatinib plus pembrolizumab combination. So how each combination is very different in which patients you can use this. So usually the discussion was pembrolizumab plus lenvatinib combination will have a better overall responsiveness. So whenever bulky disease is there, where we really require to have a immediate response or fast responses, pembrolizumab plus lenvatinib combination is preferred because ORR is significantly high. And patients who are having a bone metastasis, cabozantinib like combination scored well. And the quality of life of nivolumab plus cabozantinib patients like having a good quality of life. So in this group of patients who are a significant skeletal metastasis, it's not a wrong idea to give nivo plus cabozantinib combination. And lenva plus pembrolizumab, definitely the oral response rate, the till date, the PFS is very strong. We can offer this. It's a different thing. And what about pembrolizumab plus axatinib? That's the keynote 426. We all know axatinib is selective VEGF inhibitors. Cabozantinib is a multikinase inhibitor. Lenvatinib is a VEGF different like as well as FGFR inhibitor. So each TK is very different. The importance of axatinib is having a low T half. So whoever patient we find like they may not tolerate the combination, or whoever have a risk of having a diarrhea or colitis, frail patient, this combination we can offer because axatinib is having a short T half. We can stop axatinib. We can assess the side effects whether it's due to the TK or IO. Persistence of symptoms after stopping axatinib after 1 day, like T half is almost like 18 hours. The persistence of symptoms are there that may not be due to axatinib, that may be due to the immunotherapy. So we can gauge which drug is causing side effects because axitinib is having a lower T half, low half-life. Whereas nivo cabozantinib, the two important points I mentioned, very active in skeletal metastasis, and second is very good quality of life. Pembrolizumab plus lenvatinib, there is a good oral response rates are there, and good PFS is there. So bulky disease we should offer. To whom you will offer nivolumab plus ipilimumab? I already mentioned the very beginning that CRs are very high with the nivolumab plus ipilimumab. And second thing is good quality of life is there. So whoever patients who are not having a bulky disease, the minimal burden disease, and who doesn't want to have a TK side effects, who don't want to take a pill therapy. So those kind of patients, I do offer nivolumab plus ipilimumab. I may offer single agent immunotherapy also out of the box because like not everyone will tolerate ipilimumab for sure. Not everyone will be a candidate to give TK also. So the frail population, I suggest to start a single agent immunotherapy, preferably nivolumab because of pocket friendliness. And later I will add the TK depending on the tolerance to the immunotherapy and their acceptance to take the further pill therapy. So that's how I select my patients, which combination should be to be sorted. And of course, patients who are not affordable for anything, I do give a single agent TK. Most of us do practice single agent TK. So these are the overall responsive rates. I already mentioned pembro plus lenvatinib is having a significant oral response rates. And also CRs, if you see, pembro plus lenvatinib is having a significant number of CRs, and the PFS, if you see, comparable to any other combination, pembro plus lenvatinib is having a significant high PFS. If you see the control, almost all are equally good, but the combination Lenva plus Pembro is having a high PFS benefit. So as the time passes, we'll understand which is having a good PFS as well as OS benefit after some more follow. I thank organizers for giving this opportunity and sparing this time for me, and sorry for not joining a live session.
Thank you, Dr. Kripa.